Greetings, everyone. I hope you're doing well this evening or today or whenever you're watching this. This is PARM 2223, Spring 2020 Online Edition, and this is Unit 11. And Unit 11 is a continuation of our focus on neurological conditions, and we're going to talk about seizures. And I hope that we will give you some new information, some new thought processes on the management of seizures, that maybe you haven't had in the introductory module on seizures and neurological conditions. Maybe not. We'll see where this goes. But I had a lot of fun doing this last year, and we'll see where we do it this year. All right. So, starting. This is some of our learning outcomes and objectives. We're going to talk about the common terminology pertaining to seizures so that we're all talking about the same thing. We're going to describe seizures from a clinical context. We're going to describe complex seizures, partial seizures. We're going to talk about a wide variety of different things. And we're going to talk specifically about the management of prolonged and protracted and refractory seizures as well. So when we look at seizures, of course, definition is synchronized high-frequency neuronal depolarization that results in abnormal behavior or patient experience. And I like to think of this as kind of like the neurological equivalent of VFib going off in the brain. And often, I mean, some of the I shouldn't say some of the pathology, but some of the etiology, ischemia, infarction, decreased perfusion, toxicological are often the same. So, epilepsy is a seizure disorder. It's not the only seizure disorder out there. But it's a chronic, and I want to stress that as nobody has nobody has a new onset of epilepsy. Epilepsy is a diagnosis after other more severe causes are ruled out, such as lesions, tumors, stroke, etc., so forth. Epilepsy is a chronic neurological disorder characterized by recurring seizures. Now, these seizures, when I say recurring, may not always be visible. They may be partial, they may be absent, they may be some other manifestation. But they're recurring seizures that are not provoked by an acute injury or otherwise by a health emergency. And I put this in red because I really want you, if you get nothing else out of this, keep this in mind. Just like I've said before and other stuff, especially when I teach my toxicological lectures, seizures are neurological emergencies until proven otherwise. And by this, I don't mean we run around with their head cut off like a chicken. It means that even if they have a seizure disorder, every single time you have to take a moment to make sure that there isn't something else going on as well. A patient may have a seizure disorder, but you want to make sure they didn't hit their head, they didn't have a stroke, they're not hypoglycemic, they didn't also overdose, any number of different things. The idea of dispatch priming and anchor bias and cognitive biases that trip us up is really important in much of our practice, and seizure disorders is one of those classic ones. So the majority of the people who have epilepsy do not have other impairments and live very normal lives depending on the severity. Febrile seizures are not considered epilepsy. They're different. And there are many types of epileptic syndromes, many with their own characteristics and quirks. So what I'd take for this is I actually enjoy talking to patients, which if you're in this business, you should. So if you're transporting a patient or you're sitting with a patient waiting for them to come around, don't just get the bare bones you need for your refusal and your charting. Ask them about their seizure history. Ask them how it's been managed. Ask them what's been successful and what hasn't. Ask them what they suspect the causes are. Now, there will absolutely be some people that could give three less, and are very poor historians and wonder why you're asking about this. But there's also going to be patients who will appreciate you going the extra mile, engaging with them. And remember, we're lifelong learners in healthcare, or we should be. And you will learn something you didn't know before, or at least something you should look up and learn more about. So, moving on. So some of the definitions and reasons, this is from the Epilepsy Foundation, and we really have to make sure, just like with the rest of medicine, we're using the same terminology. So we look at this, a brief seizure. Brief seizure is usually lasting less than 5 minutes. A prolonged seizure is anywhere from 5 to 30. Status epilepticus has several different definitions, and I want to qualify this by saying this is the Epilepsy Foundation. In our area, there is our couple neurologists that have always used the 20-minute benchmark, so there may be a couple regional differences, but 30 minutes of continuous seizure activity. Now, I want to point out that continuous seizure activity is actual seizure activity, not just visible seizure activity. Because after about 10, 15, 20 minutes, there is not enough ATP for the continuous tonic-clonic activity that we normally associate with seizures. A casual observer, an observer who's not being astute, a lay observer may think they're just passed out when they're still in seizures. Status epilepticus is also 2 or more episodes of continuous seizures without the return of consciousness in between. And some of the guidelines expand that to in a 30-minute period. I've seen seizures much longer than 30 minutes, and we'll talk about that. So, moving along, some further definitions. Ictal, the interictal period is during the seizure. The post-ictal period is, you may have guessed it, after the seizure. Interictal is between the seizures. Aura is, these are kind of abnormal sensations that are believed to be actually not a warning but simple partial seizures before they escalate to full-blown generalized seizures. And there's been a lot of different manifestations of this, and sometimes these are mistaken for TIAs and strokes. And we'll talk a little bit more about that, but there, could be sight, visual disturbances, seeing spots, so on and so forth. Smell. They smell, if you're a Warehouse 51 fan, Warehouse 13 fan, they might smell fudge. Look that one up. Any number of different things. And they usually precede a more generalized seizure, but not always. And we'll talk about some of the cases where they may not. They also may describe, and this is very particular, kind of a sensation, nausea can also be an aura immediate before, with this kind of just this pressure that rises from their stomach on up, and we're going to talk about that with the vagus nerve. There's actually quite a bit of pathology and pathophysiology with this that we're just going to get in the tip of the iceberg. It's going to be real difficult sometimes to determine between a post-ictal state and an actual prolonged seizure. So don't just assume because somebody's no longer jerking that the seizure's done. Look at their eyes. Look for the rapid eye flutter. Look at their respiratory rate and pattern. Look for any signs of rigidity in their jaw and anywhere else. In other words, don't do just a foot of the bed assessment. Actually lay your hands on the patient and do a comprehensive assessment. So we talk about the tonic phase and the clonic phase. The tonic phase is muscular rigidity. Clonic phase is actually the kind of back and forth jerking. So that's where we talk about the tonic-clonic phase. Atonia is flaccidity. And myoclonic jerks sometimes precede full body generalized seizures, and they're almost Parkinsonian. You will also see myoclonic jerks, myoclonic twitches in the mouth and jaw, with some that can be mistaken for trismus when succinylcholine is administered, with certain other toxicological compounds as well. So none of this is specific to epileptic or idiopathic seizures. When you talk about new onset of seizure, we're talking about occurrence of a seizure without a previously diagnosed seizure etiology. So I've found patients who have had seizures in the preceding month and they're still trying to figure it out. I would call those new onset. I may classify as new onset, currently under investigation, as opposed to new onset and nobody's taking a look at the patient at all. A recurrent seizure is a second or third or fourth or fifth, whatever, seizure within a 72-hour period. And about 10% of the patients that we encounter will have this. These are usually due to metabolic changes, non-compliance with medications, but not always. They are always cause for concern, and we recommend evaluation. So let me give you an example. You go out on a patient, they have a seizure, they're post-ictal, they come to, you're thinking about doing a treat and release, they want to do a treat and release, and then they mention, the other medic that was here yesterday let me treat and release. Ding, 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 ding. What do you mean the other medic that was here yesterday? Oh, I had one of these yesterday and then another one last night, and we didn't call. I wouldn't have called this time, but my wife or my spouse or my significant other or my dog all activated 911. That should tip you off that something is not managed about their seizure condition, and they need to figure it out. And there's lots of reasons, including sickness, fever, dieting, activity changes, weight gain, weight loss, etc. I mean, lots of different reasons why this occurs. Refractory seizures is ongoing seizure activity despite the treatment of benzodiazepines. We want to spend a little bit of time on refractory seizures, so bear with me on that. Breakthrough seizures, these are seizures that occur despite appropriate treatment. Now, I'm not necessarily talking about treatment that we give. I'm talking about their day-to-day treatment, their Depakote, their Dilantin, whatever. They're taking it appropriately, and then they still have the occasional breakthrough seizure. And that is usually an indication that their meds might need to be adjusted, or they might have to look for other potential causes, medication interactions, etc. Noncompliance is a common problem, and these are people who don't take their anti-epileptic meds or their anti-seizure meds for a wide variety of reasons. Sometimes it's financial. They can't afford them. Sometimes they don't like the way they make them feel. Sometimes they have other mental health or socioeconomic issues or social issues or psychosocial issues that makes them non-compliant with all of their meds, not specifically those. Or sometimes they may be taking them, but they're participating in comorbid activities such as drinking alcohol, stuff like that. So there's lack of family support, especially in children, parents who aren't on top of their teenagers taking their meds, and their teenagers don't, or their teenagers are selling their meds, or any number of different things. And how are you going to know this? You're going to know this because you're going to play Sherlock Holmes, and you're going to dig into their history. You're going to ask these questions, and when you ask it of them, you're also, if appropriate, going to look at their spouse and say, hey, wife, is he telling the truth? Is he really compliant? And you'd be surprised how many would say, hell no. You know, he doesn't take it. He'd rather go have his beer, whatever the case is. So that's probably, when you get out into the field, these are some of these calls where you're going to take along to your EMT partner, your old grumpy paramedic partner is going to be rolling their eyes. Why is this young whippersnapper medic taking so much time with this patient? I want to get back to watching the Kardashians, or I got my dinner on the stove, and we all know this is just a post-ictal period. Why is this young medic taking this extra time? And you're going to take this time because of this class. You're going to learn that taking shortcuts leads to bad outcomes. You have to be rigorous on this. You have to dig in. Getting a history is 70% of your assessment. So pseudo seizures. Yeah, I want to just take a moment here that we all have made, where somebody says, "Oh, she has pseudo seizures," and you're looking at them, you're like, or psychogenic seizures is the other one, where you're looking at them like, yeah, they're faking it. They hand drop tests, so on and so forth. Just because there's a psychological component to their seizures does not necessarily mean it's not a serious issue, or that they're not having another issue. So be really cautious in just discounting them. Now, that said, these will manifest themselves often pretty different with, no post-ictal period, peeking out of their eyes, looking around, so on and so forth. But there are the whole so-called pseudo seizures is a broad category, and do not discount them. So you have the psychogenic non-epileptic seizures, which I mentioned there, and the organic non-epileptic paroxysmal symptoms. And those particularly, a lot of times the patients just lump them all together, but this last category are your lesions and your space-occupying lesions and your tumors and the other things that they can't quite figure out. Complex migraines can manifest themselves both as strokes and seizures as well, as can tumors and actual strokes and seizures, or strokes. Yeah. So, how do they tell the difference? Well, believe it or not, there's not a tool in our ambulance that can tell the difference. These are patients that usually get a sleep study. They get a EEG, several EEGs, and it's really a diagnosis after they've made sure there's nothing else more severe. Now, here's something you need to be familiar with: Todd's paralysis. Todd's paralysis is often mistaken for strokes, and for good reason, is because they look like strokes. They're focal motor deficits on all or part of the body after a seizure. Now, this usually affects appendages and or the right or left side of the face, and it usually subsides fairly quickly, but can mimic a stroke and subside or kind of have residuals up to 48 hours. You're going to be justified and perfectly appropriate to take these patients in if they have residuals. But just understand it may not be an actual code stroke per se. And if they've had a seizure immediately preceding that, that's usually an exclusion criteria for code stroke programs. Still means they get all the other evaluations, and then they might be upgraded to a code stroke later. But seizure preceding stroke-like symptoms is often Todd's paralysis. Again, don't discount the fact that the stroke may be causing the seizure, especially if there's no prior seizure history. Don't discount the fact that this may be, again, a non-epileptic presentation of seizures. That's all your tumors, your toxicological stuff, so on and so forth. So we're going to take a quick break, and we'll come back and with our next portion of this lecture where we talk about the pathophysiology of seizures. Thank you.